And we are live.
Wonderful. Just waiting for my computer to catch up. However, I should perhaps start introductions. Good afternoon, everybody. Welcome to the Paediatric scenario section of the CPR or resuscitation competition. As you have heard from many of my colleagues, the entire conference has taken a completely different track this year. And the resuscitation competition is indeed no different. Ideally, we'd be bringing everybody together and delivering a demonstration of high quality resuscitation live to a large in-person audience. And so we've now had to adapt and change things some significantly to allow you to see what I hope will be some very, very high quality demonstrations of the best way to deliver good quality resuscitation, non-technical skills and adherence to the resuscitation guidance. I'm going to hand over to my co-chair at this point to outline how the competition works before we introduce our judges. So it gives me great pleasure to introduce Lucas Fancel-Wizicek.
Thank you very much, Robin. So yeah, we're gonna shortly introduce just the outline of the competition. So in principle, we ask to send us in from each National Resuscitation Council videos for the 3 course formats, ALS, EPOS, and NLS. Those videos were screened by our experts of the Science and Education Committee. They reviewed the videos and they were also available on the platform to be publicly viewed. Now, as of today, we will have these dedicated sessions where the experts will show some scenes. Eventually, there will be then the votes of the SEC members. And at the end, those votes will be pulled together with the ratings of the National Resuscitation Councils. So we will will have those 2 components pulled together. Besides that, and that is also what we are looking forward right into this very first session, is the public voting. So please, everyone who is right now in this session, use the possibility to vote on the different aspects of the demonstration videos, because we're also keen to get your opinion on how you rate them. Yeah, that's basically it. So please actively participate, use the Q&A, use the poll function, and I'm right now handing back over to Robin.
Thank you, Lucas. Just to add that all of the videos in full are available at the bottom of this page, so you can view them at the end of this session, go back and pause or review different areas and elements to get a really good feel for some excellent work that has been produced. So without further ado, it gives me great pleasure to introduce our 2 facilitators and judges this afternoon, both good friends and esteemed colleagues of mine from the years of time in the European Resuscitation Council. They both happen to be chairs of the Paediatric Life Support Committee, my good friends Patrick van der Voorde and Ian McConaughey. Thank you, gentlemen.
Hi. Thanks again as well, Robin, for together with Ferenc and Lucas, all the work you've been doing in pushing this resuscitation competition as a essential part of an ERC Congress, even if we go virtual. It's a great pleasure to also have Ian here as a co-chair, who is much more experienced than me in all these resuscitation things. And yeah.
That's shorthand for older, but not necessarily wiser, Patrick.
But you have a fancy background. I think I can say that the task we gave you is not an easy task. So in the beginning, you are all winners. It's especially difficult in COVID times to do videos, having all protective equipment, trying to talk and communicate. We are very much aware of that, and there were some really impressive performances. That's also why we decided to not pre-select only 2 videos, but allowed every video to at least have some discussion in this session. It's obviously simulation, and we are aware that This is only an approximation of reality, but we appreciate it if teams try to be as realistic as possible, and we show some examples of that as well. I do not know, Robin, if there's anything more to say before we move into the first video.
No, I think you can continue, Patrick. Thank you.
Thank you. So the first video we would discuss about is the one of the team of Austria. What we do is I will show some parts of this 25-minute video to you and to the team we have here in the meeting, and then we can discuss a bit on what we thought was specific for this small part of what we are showing. So let's share my screen. This is the first part. Actually, the sessions are always split into 4 parts in a way. There's the allocation preparation, there's the ABCD approach, and then there's the arrest scenario part where there's a quality of CPR and non-technical skills. And finally, there's a short post-ROSC evaluation and planning to the scenario, ending with a debrief. This is from the preparation.
I do chest compressions.
Leo, you will be responsible for the defib.
Defib.
Dominic, you will be responsible for mom. Please do a thorough ample with her.
I take care of mom.
Okay, guys, do you have any questions or suggestions? Dominic?
Yeah, shall mom be in the same room as Chandler because of COVID?
Good point. I don't want mom to be in the same room. Leo?
So I'll keep the screen open because we will then move on to a second time slot. But I just wanted, I think, what I very much liked about this preparation was that there was a clear, good, close communication where everybody had a clear task, and there was also a bit of anticipation of what would happen, and parents were accounted for. This is something that in the other scenarios come back as well, but here there was definitely a clear plan. I wonder if it's really necessary, but I'm happy to also hear Ian on this, to have parents outside of the room with regard to COVID. But the fact that the team also could ask questions and make suggestions is, I think, a strong point.
Yeah, thank you. So if I can just chip in there, certainly, and we've got a presentation later on today about family presence in the resuscitation room. The aspect that we took for BLS in ILCOR, and Patrick, you remember this, was that we thought that if a child had COVID or if a family had COVID, then it was most likely that we would have to protect ourselves against that eventuality. So there is something about the use of PP in the scenario, which is really important. And if it is truly a cardiorespiratory arrest, intubation may well be needed, which is an aerosol generating procedure. So these are things to think about. So preparation beforehand, and as I say, certainly the audience will think about later on about family presence, but I'm not sure it should inhibit family presence.
Okay, I'll go to a second slot where the child has just arrived and the ABC approach is starting.
Is not reacting. No visible secretions. He's snoring.
Okay, so Bernhard, the airway is at risk. I recommend placing an OPA.
Airway at risk, place an OPA.
Placing OPA, Bernhard.
Kati, pulse ox, blood pressure, 4-lead ECG.
Starting the monitoring.
Leo, IV line, if unsuccessful within 1 minute, IO line, and draw blood samples.
IV line and blood samples.
So Bernhard, he's tolerating the OPA.
Okay, so Flo, let's assess P together. Please auscultate the lungs and examine.
This is, of course, then going on a bit further on, but I thought, and this is coming back also in subsequent scenarios from the other teams, that there might be something to say about how a team works in this sort of process, and whether or not you could optimize this in terms of decision making and speed of support for this child. Maybe to clarify for the public, because you might not have known, this is a 5-year-old child who has gone to bed after lunch and doesn't come downstairs. His mother eventually finds him unconscious in bed and runs to the ED that is just next door. So the team has a little bit time to prepare and are confronted with an unconscious, superficially and very slow breathing child. He is not in arrest at that stage, but he's hypoventilating and in circulatory failure. And that is the scenario they are working with. I don't know even if you have any comments on this setting.
I think that's absolutely right. In reality, you often do get a call, for example, from an ambulance service or whatever, giving a history about incoming, and preparation is really important. One of the things I would say about this is that unlike here, where people know each other, in reality, you often get people who you don't know. So identification of those people and directing them by name, such as, say, Bill, the anaesthetist, can you please do the airway? Can Simon look at the breathing, and so on, is a practical element. Really important as a team leader to know people's individual names so you can instruct them. But again, this is in context of a sim. So I'd say slightly more flow might be useful, but I'm now being very critical.
No, I think what I find in this team, and all true, and maybe this is even a cultural thing, but they are very much at ease, very thorough. There's no stress, and that really works well for a team if you can have this sort of environment. So that's very positive. What I miss a bit, but this is also maybe because it's simulation, is that in this very strong team leader role, your team members do not react very proactive, and then you lose away time. If we measured, it takes up to almost 2 minutes before backmask ventilation starts, where eventually already in the first seconds the B person would see that the child is actually not very much breathing. So this is sometimes maybe a plea to have a team members that are more proactive and a team leader that is just coordinating and not maybe so strict in his guidance. But I would like to work in the environment, definitely. And then I quickly go to the end of the ABCD approach. This child is still not in arrest, and there's a very nice...
So guys, team update, all eyes on me. We have a critically ill child with the need of ventilatory and circulatory support. Our current working diagnosis is an intoxication, potentially due to food poisoning, but can be any other substance as well. What other differentials can we think of?
With the low body temperature and the low blood pressure, I'm thinking sepsis. So we should apply more fluids that could be beneficial for the patient.
You have the impression that he's not breathing anymore.
The last voice was the instructor to the scenario, and obviously there will not be much breathing if the child is already backmask ventilated. But then again, what I found from this scenario is that the team leader makes a nice summary and interacts with his team to have that status and that situational awareness, the whole team. He also pushed forward a working diagnosis, but asked the team to have input on that. What I just wonder is the working diagnosis of food poisoning came as a bit as a surprise for me, because I did not have any clue in the story where that would come from. And I also wonder, but that's maybe something to discuss, if it would really think this is a sort of an anaphylactic reaction, why the team did not consider adrenaline. Hello, Ian.
Sorry, very fair comments, I think, but you're quite right. I think seeking help is really quite important, opening up conversations to other people, because there may be expertise that are represented by the three others that can contribute. So I'll take your point absolutely, Patrick.
Then for me go to the last sequence I wanted to show from this very nice done video. They now have identified the child to be in presumably cardiac arrest, which is a non-shockable rhythm. And
breaths.
5 rescue breaths. Do you assist me, please?
Kati, fingers on the pulse.
In position to feel the pulse. 2, 3, 4, 5.
Do we have signs of life?
No signs of life, no pulse, no breathing.
Kati, start chest compressions.
Starting chest compressions.
Leo, defipads.
Defipad.
Flow ventilation.
Ventilation.
Team update. We are in.
So this is the start of the CPR sequence. I should have maybe shown it a little bit longer, but I can explain in a minute. What I've seen in most teams is the difficulty, and I don't know if Ian has an opinion on it, when you're already ventilating and you recognize cardiac arrests as such, do you start immediately with compressions, or what is then the place of the 5 rescue breaths? Here they were very much clear on doing 5 rescue breaths. I think they even did them at a sort of a higher tidal volume, as if in a smaller, or a neonate sometimes is discussed, but they actually chose to go for 5 rescue breaths at the start of this sequence.
I think that's fine, because they're sort of thinking strategically along the pathways.
Mm-hmm. What I've also seen, and that is completely correct in COVID times, is a 2-person approach to bag and mask ventilation. What I maybe did not show in the video, but which all teams struggled a bit with, is with timings. And of course, in the video, you can start adjusting afterwards. And some teams also did some editing of the video, I think. But the 2-minute cycling was sometimes difficult to keep up with. It might be because of the format, or it might be a thing that would happen in reality as well. But quite a lot, it was 3 minutes, or in this team, actually, the problem was that they did, and maybe I can, you still see my screen, I can show you.
Cardiac arrest.
Patrick, sorry,
Remember, guys,
your comment.
15 compressions.
What is, sorry?
Patrick, sorry to interrupt. Your comment in timing is perfectly timed, because we need to consider moving on to the next video.
Okay. I can just tell you then here, because I think it's still an important thing to highlight this with this rhythm check, is the patient was actually already on the monitor. And as soon as you have a monitor available, you can actually evaluate whether or not this is a shockable or non-shockable rhythm. You do not need a second real stop to do so. But otherwise, from here on, the CPR and also the post-ROS goes very smooth in this scenario, I must say. I will stop the screen sharing to go to the next video. Unless there's any comments, we immediately move on to the video from the team from Tunisia.
Yeah, just to step in here shortly, Patrick, we have one question right here, and it is about the viral filter, if it has been attached while bag mask ventilation. So directing to COVID-19 guidelines, of course.
I think it was from the beginning when they started back mask ventilation, there was a viral filter in between.
Okay, thank you. Then I think we have sorted out this question, right?
Yeah. So let's share my screen again. So
Someone help me! Someone help me!
This team took a little bit a different approach by adding some drama to the movie, which was very interesting. They also acknowledged the fact that there's a mom there, but had a bit less plan on what to do exactly with her. The CPR, the ABCD approach then starts the ABCD approach then starts, but again here as well, the team members. Let's see where I get. So I'll go to here.
Work of breath, auscultation is normal, superficial and slow. Saturation in air was 89%.
You're already then.
We need to ventilate the patient with the bag mask, adequate bag mask, okay?
So I think, and this is maybe a result of being in a simulation setting and not visually seeing the child, but this team too had a very central role for the team leader. The team members definitely did a lot of work, but the decision to start back mask ventilation, for instance, was the one of the team leader down the line.
Yeah. And again, just to comment, I think that because it is a simulation, there may not necessarily be the progression through the steps, for example, about airway opening and so on, working up to it. And as you said quite rightly, BVM with 2 people is very helpful. It may be helpful to think about doing a jaw thrust and sort of accommodating best airway opening techniques. That's just a general comment.
No, absolutely, and it's a difficulty. We all know how difficult it is to work in these COVID circumstances if there's really a critically ill patient, because you need to think of so many things and there are so many risks. What I did not show yet is, for instance, once you've intubated, and I show you the sequence now. There's obviously also very specific way of doing.
The estimated weight is 18 kilograms, so please give 1.8.
I'll go a bit earlier because there's something else.
Please prepare for intubation with video laryngoscope, okay? The patient is in asystole, it's a non-shockable rhythm, we need to prepare adrenaline. The estimated weight is 18 kilograms, so please give 1.8 milliliter of adrenaline, 1 to 10,000 flushed with the normal saline, okay? Guys, we need a high quality CPR, okay?
I'm ready for the intubation. Intubation is done.
Okay, I think I've shown enough. There's a few interesting things here. I think which have to do, of course, with the intubation as a procedure. I think it's indeed video laryngoscopy in COVID times might be interesting. In reality, of course, the procedure is even more complicated than shown here, as in arrest or not in arrest. I do not know, is video laryngoscopy something that is generally advised as for use in these COVID times? In protocols in the UK or?
No, it's quite very interesting.
Mm-hmm. I think that for people who are used to work with it and have had some training, it might be an interesting way because you do not have to be as close to the mouth as in direct laryngoscopy. What is important, I think, is normally that you clamp the tube once it's in, so that you have less spread of aerosols. What I also saw, and this is team coordination, I do not know if the rest have seen it, is that the one that actually is doing the back mask ventilation at the head walks away to prepare for the intubation, and that leaves a moment of confusion for the person who is not at the head. So there they could have probably coordinated as a team a little bit more to avoid this glitch. What is a difficulty, and people might have already listened to the draft of the guidelines when making this video, because what is in every video was a difficulty is how many times do you ventilate once you have a tracheal tube in place and you are doing continuous compressions. Each of these videos had a different rhythm in their minds in a way. The guidelines of 2015 still speak of 10 per minute, but we acknowledge that I think a lot of people are not doing this in smaller children. And
so people may know there's a paper that's come, the first author is Robert Sutton, which identifies that the rates are between 12 to 20, which may be associated with improvement, but it's a single paper. And it's something I know, Patrick, that we've talked about, and others in our task, and writing group have also considered. That's the only piece of evidence I think at the minute to suggest higher rates, but it's something we need to think about.
What you see in reality, and what we see also in these 4 videos, is that actually most people go faster. I think these are the most important things I wanted to show of this video, which then actually has also a strong post-resuscitation part. The team ended up with a tentative diagnosis of food poisoning as well, which again surprises me, but this was at the end of the scenario, so no discussion about the need for adrenaline then, because that was after the arrest that this was the conclusion. I do not know if there are any other things to highlight or clarify.
I don't think so.
Well, if not, then we would have 2 questions from the audience specifically to this video. So the first one is if the team did inflate the endotracheal tube cuff prior to providing ventilations. So that is the first question.
Well, what I think I've seen is that, of course, and this is always in simulation when you do not have quite often the dummy is not specifically meant for intubation, and then the procedure is not done in the full way, and I do not think that things like cuffing or proper fixation of the tracheal tube were then part of the video, which is a simulation thing, I think.
Yeah, I think I would agree too. So as far as my impression is that the first team, the Austrian video, used some sort of ALS Sim Junior, and now we have here a different mannequin. That's probably why the fidelity of the simulation is quite different. Now, Patrick and Ian, second question that we have is, was there a pause to chest compressions to get the tube in?
I can take that. There was actually some pausing and some choreography where the back mask ventilation already stopped, and then there was a search for an optimal timing to do the insertion of the endotracheal tube. Yes.
Thank you.
It only took seconds, but it was there. That's
okay. And just a short comment that we've received also from Janice N, who posed the first question, that this was just related to COVID-19 to reduce the risk of aerosolization. So that was her comment on that. And then we have yet another question, which is not directly related to this video.
Lucas, sorry to interrupt. Yeah. Perhaps if we have time at the end, we need to come back to that question. Yeah, we need to move on to the next video. Thank you.
Okay. I'm just gonna close this one. And then we are going to look at the video from the team of Germany.
Welcome to Germany.
I'm just going to
maybe I'll pick up a question that you posed, Robin, whilst this is coming up, which was about the use of the use of video laryngoscopy compared to direct view. There isn't an evidence base, as far as I'm aware, in paediatrics as yet. We did. Yeah,
you can continue.
Sorry, as far as I'm aware, there isn't yet studies looking at the two, but I think the point was well made that for safety's sake, it may be easier, but thank you.
Okay, so then for the German, I will not, and to keep our time and have a bit time for discussion as well, go into the preparation part. There was actually very clear, very well prepared. All teams do not anticipate very much, which I think is normally a strength if you also think already about what can happen, and if this happens, what can we do? This helps the team to better prepare, I think. But the plan was clear. The German team also decided to have the quick look, and so the initial appreciation done by a team member and then brief to the team leader, which is a decision they can make. They all look very impressive as well. Which will not be an easy thing to do working in these circumstances. I'll start with the actual start of the ABCD approach when the child arrives, because there's two nice things to see.
Voice unresponsive, very pale, and there's much vomit on the shirt.
Very pale.
On the pale, we have a white child.
We have a critical patient. Chandler, can you hear me? Hello, can you hear me? Open your eyes. Can you hear me? The patient is unconscious.
That's right.
I check the airway. The airway is clear.
Yes.
Then I check the breathing. The respiratory rate 6 or less, and it's superficial. We need assist ventilation now.
Tina, please start the ventilation. Use the double C handle because of the COVID pandemic. Jonathan?
Yeah?
Could you help her, please?
We have a central pulse, and peripheral we have a...
There you go, and then they start back mask ventilation. So in this way, there's a bit different than the previous teams in that they throughout this whole ABCD approach, they communicate very well, and they are equally at ease and thorough as the Austrian team. They have nice close communication loops, and they identified the need for BMV in the back mask ventilation in the first seconds. They were also, and I do not know if it's used in every country, the only team that used a Brusilov or a Brusilov-like tape to have their vitals and doses and such things. I don't know, Ian, if there's a...
No, I thought this was quite different in terms of the management. You're right, there was a fluidity about it, but again, it's always about control and command and how things go on. And again, in reality, you will have people of different experience and skills and so on.
Then move a bit further. To the start of the CPR. It's about here.
Okay, team time out, there's a change in the vitals. Dominic, please repeat ABC.
I repeat ABC, stop ventilation. They always clear.
Yes.
There is no breathing.
No breathing.
No pulse. We have a bradycardia PEA. Start CPR.
Tina and Jonathan, start CPR 52 and continue for 2 minutes. Yes. Dominic, apply the CPR feedback model and start the metronome.
Yes.
5, 4, 3, 2, 1.
1.8 milliliters, water increase 1 to 10,000 solutions. All right.
5, 4, 3, 2, 1.
More releasing, Jonathan.
Yes, okay.
This is the start of the CPR. I don't know, Ian, if you had specific things you liked about this start, or
again, I think it's you're always wondering about the depth and rate of compression and about the GT cycle. I was just wondering if there was leaning going on. If you can see here the position of the body, the person delivering it, I would just be a bit worried. I don't know what you thought, Patrick.
Yeah, it might be. It's always difficult to appreciate, obviously, on a video coming from this angle. So it might be a visual effect as well. I was a bit confused, but this is also a video thing, I think, with a 5-to-1 calculation, which in effect is probably a good thing, but was not completely synchronized with the CPR as such. Here they immediately went for compressions because they were already ventilating anyhow. So this is a difference what I was talking about. It's a bit unclear what you best do in this sort of circumstances. I do not think there's a big difference there. But correct me if I'm wrong. And then because you were talking about CPR quality, which we obviously in every video will appreciate, because it's important, and CPR quality is important, not each part of it separately, but combined. The number of compressions where your rate, your depth, and your recoil all are good. How many of these compressions are you doing? The team is now further down the line.
Yes.
The first bolus was inside.
Thank the first bolus.
And there's definitely good recoil.
The ventilation is working. CO2 is coming.
Great.
Good chest rise.
10 breaths per minute. Avoid hyperventilation. And Dominic, yes.
Which is a thing that all teams sometimes struggled a bit with, I must say. And then my final piece for this team is at 12:02. I'll start at 12. We are now in the post-resuscitation phase. We actually, is the first time we show this, but all teams did it rather well.
35 and 45.
Planning everything.
Oxygen saturation should be between 94 and 98%. Yes.
We have a pulse perfect.
Yes.
I check the pupils.
I'll do it a bit further. I'll do it like this.
For a moment, please, Tina. Yes. Target and tidal CO2 should be between 35 and 45. Oxygen saturation should be between 94 and 98%. Yes.
So this is about the targeting, and in post-resuscitation care is about being brain protective. There are definitely targets. You want to have a sufficient high blood pressure, and you want to have targets for oxygen and for capnia, PCO2. So for oxygen, the team leader tells her team to go for 94 to 98. And for PCO2, she tells her teams to go for an end-tidal CO2 between 35 and 45. I think I forgot the exact. But now the first one is definitely true. But I think, and I'm also looking at Ian, one has to be very careful with using end-tidal CO2 as a surrogate for PCO2. Quite often, and unless you have done a blood cast that really shows a match, there might be an important difference. And for instance, if you have an end-tidal CO2 of 28, this does not necessarily mean that you're hyperventilating and you should decrease on your ventilation. I think that's an important thing to consider. I don't know, Ian?
Absolutely right. And again, we've discussed this at length with the end-tidal CO2 ILCOR statement that came out, which was really about tube placement. Its use as efficacy for CPR depends really on the origin of the cardiac arrest. So if there's, for example, perfusion and or ventilation mismatch, it can be quite difficult. So you have to be very careful with end-tidal CO2.
Mm-hmm. And especially once you're post-resuscitation, it's a surrogate marker for capnia, but only if you matched the two, because there can be a difference because of ventilation perfusion mismatch. Very well, I do not know, because this is our analysis for the German team. I do not know if there are questions in the Q&A or...
Again, I think just so that we allow time to get through all of the videos, perhaps if there are questions, we save them for the end. Does that seem sensible, gentlemen? Okay, thank you.
Maybe Teun can also show the second Slido question instead of the first, so that we have an answer on both questions. Okay. And then I'll move to the last video, which is from the team of Turkey. Stop share, and I'll first make that ready.
Turkish team.
First make that ready, and then I'll share my screen again. There you go. Back in. The Turkish team had a very long preparation part, but what was interesting is that they allocated roles to the team before the story was told, which could be also a reality if you work with a team where you know each other's capacities, and you have in the beginning of the day, for instance, a role check. If there's ever going to be a problem, you will be responsible for airway breathing and you will be the support. I think this can work as well in teams that are working together during the whole day, for instance. And then we go to minute 6.18. I'll start a little different. So here the child has arrived and the team leader is actually has done a quick look and is now going as a team lead from A to B to C.
Open.
Okay. B. I am listening for lungs. Is there any extra sounds for lungs?
No extra sounds.
Is it echo?
Yes.
Is there any work of breathing?
No work of breathing.
What is the respiratory rate?
It's slow and superficial.
Slow, superficial. We can see SpO2 now. Can I contrast, please? Tell me what is the SpO2 and respiratory rate is?
The SpO2 measured as
989.
And the respiratory rate?
6 per minute.
Okay, it is 2 days. So, Onur, please translate him with balloon mask.
Okay.
With oxygen.
These are adult pets. I patched this anterior posterior.
Okay, very good idea.
Pregnant ventilation start.
What is the...
So there were few things that were also maybe already said in the other teams, which come a bit back, and it is definitely something we maybe even have to take up further in our teaching. The team leader was very systematic, has a good framework of evaluating B and C, but was indeed here too the one doing most of the evaluation, and as a result, actual back mask ventilation took at least 1 additional minute before starting. And again, that is also a simulation thing, but I think that is also, in my opinion, related to the more single hero principle that quite often is still happening also, I think, in reality. The team then works very systematically through their ABCD approach, but one after the other. And what I could not hear, but maybe it was anticipated to be doing, but I think it's important to emphasize, as is an unconscious child, definitely there's a place to have a glucose check. And some teams did it very explicitly. Maybe it was here implicit, but we could not find it here. I'll move forward to a difficult action to do.
That's nice.
I'm ready for
Or
the
intubating.
Okay.
If you are ready.
This is still pre-arrest.
What about E? Oh, is there any signs for anaphylactia? No.
I think it's especially in COVID times, this is a difficult decision to make. Obviously, this child not breathing needs respiratory support, and back mask definitely, especially if you're not unable with the team to do it in a two-person approach because of hands, which they also already identified also in the debrief, then at some stage a tracheal tube has an advantage. I noticed that they also used video laryngoscopy here. But this is actually pre-arrest, and I don't know, but that would, I'm looking at Ian as well, I would think that you would at least need some induction medication at that stage.
Yeah, I completely agree. You've got risk of vasospasm, you've got risk for aspiration. When you intubate someone, it's a big commitment, and therefore preparation is really important. Having suction to hand, having agents to get you out of trouble, really important. Just coming back earlier, one of the things I think, and this often isn't done very well, is just the basic examination in terms of percussion. So again, we had a child who came in who we picked up a tension pneumothorax on percussion, and I just think it's part of the drill that everyone should do. But I take your point. Intubating a child who's not in cardiac arrest is a big commitment and is difficult often.
Mm-hmm. If you're saying, and this is, I haven't seen in any of the videos, which is not a problem, but I'm just wondering, ultrasound has come the new stethoscope. Would you say that?
So again, the co-star that we wrote showed there wasn't very good evidence for the use of ultrasound, and there were a couple of cases of children who were shown on ultrasound to have cardiac standstill, who were crashed onto eCPR, who made a recovery of variable neurological outcome. Mm-hmm. But ultrasound is quick, it's available. If you can use it, as you say, to determine pneumothorax, you can use it to determine for example, the presence of pneumonia, of fluid collections. So yes, I just don't think the evidence is there for ILCOR to pronounce on co-stars, but there can't always be necessarily evidence for everything. So no. Common sense is important.
And this is still in the pre-arrest phase in a way. But if you're saying percussion, for instance, I would challenge that with. I didn't do that. I would challenge that with maybe just put the ultrasound on it, and then you also see the pneumothorax in a second. Otherwise, I must say, then the child goes into PA, and the team actually performs a very good sequence of very timely. There's again a bit of the doubts about the rate once the continuous compression start is 10, 20. They ventilate at 20 per minute, but otherwise they do a very clear-cut CPR round. And that was my analysis of Turkish video. I think we now have 10 minutes left to do some general discussion. I'll stop the screen sharing.
And again, as you thank all the teams for taking so much effort in terms of producing these videos. It's time consuming, getting everything in order, getting all the camera angles. It's quite a considerable amount of time and effort. So I think we all appreciate this.
Thank you, Ian. Took the words out of my mouth. How are we doing for questions, Lucas?
Yeah, so we have, first of all, we have one comment that was raised by Dominique Biaron for the German team eventually, where she picked up the point of the chest compressions and the leaning on the thorax. So, I mean, we've discussed this, and it's quite always a difficult issue to judge that by video, but I don't know, Ian and Patrick, if you want to comment on this.
Can I add a supplementary question / statement to that? And I think this is as much about simulation as it is anything else. How best to demonstrate the performance of high quality CPR in a simulated situation? What do we have to hand that will allow us, not only necessarily in camera angle, but any other technology, or how best we demonstrate that we're getting this absolutely right?
This sounds like a bit of a leading question, Robin, because as you know, there is a PD rescue collaboration that's going on at the moment. It's an international study, I think with one of the manufacturers, DFibs, where you can look at the duty cycle and there's feedback at the same time. And I know most people are aware about this, that the feedback loops will enhance performance if visually done. Some people have used sort of metronomes in response, but maybe a combination of the two. But Robin, I think this is much more in your territory, if you'd like to comment.
I think the technology in the mannequins has been useful in adult simulations, and it's beginning to make its way down into the smaller people. And there is some evidence to show that that improves the CPR quality delivered during training. Whether that actually translates into clinical practice or not, I think there's still a little bit of a gap in the evidence. But really, I was thinking, can people who are demonstrating this during teaching, be it video or be it live demonstration, can we adapt the technology that we have to make it really, really clear that we are compressing to the correct depth and at the correct rate and correct duty cycle and avoiding leaning and all of that kind of thing. And I think, you know, we've seen from these videos that demonstration is an incredibly powerful tool. You know, and I think working towards doing the best quality chest compressions is such a crucial component of what we're doing.
And again, there are some mannequins, as you know, that light up or indicate about the depth and the location and so on. And I think there's I think some of those figure in the industry element of this this congress as well. I'm not advertising anyone in particular, but there's a lot of activity in this to produce good mannequins.
There's actually two of the teams used, at least two of the teams used additional feedback devices. And I think one of the teams also put the output of the feedback device in an overlay screen, so you could actually see that they were doing compressions at the right depth and rate. which was an interesting thing because you can indeed have an overlay window in addition to the actual window.
I think what is also very important here to consider that anyhow, each technology that you use also in reality that can give you some data really should also be used in the debriefing. So we have had a coaster on this on debriefing of resuscitation performance, and eventually all those studies used data-driven debriefing. And I think also for simulation purposes, we might also really take this data because it's useful, and certainly for treating our real patients, the evidence points towards that this is affecting outcome and process parameters. So we didn't take a look right now at the debriefing of all those teams, but I strongly support the idea that if they use such technology, that they integrate it and really talk about the quality of the resuscitation parameters afterwards.
Absolutely. I think the most debriefs were using definitely learning conversation, which is a good thing, but did not highlight. They highlighted the general feeling of the team, and there was a lot of feedback going on, but they did not highlight any potential issues nor any data from during the resuscitation at this stage.
Yeah, now time is running, and we still have got some minutes left. So in terms also for the questions, I would rather say that we move on to the polls right now. What do you think, Robin? So you're still on mute?
Yeah, that seems very sensible.
All right, then I think we have polls on different aspects of the simulations. So the first question that we had was which of the teams performed the best preparation and task allocation and subsequent ABCDE approach. So we might now take a look at the results. And as far as I can see it, we do have the Turkish team here still in the lead, but there are some live votings going on. But it looks like that they are ahead of Team Austria and Team Germany. Now slightly the tide seems to turn in the second place. But I think regarding preparation, allocation, and ABCDE, we have a winner from the public voting. Robin, I think, can we conclude on this?
That's all of the sections covered, isn't it, for public voting, I think, Lucas?
There's a second question.
The second question, maybe?
Yes. So we do have the second question regarding the quality of CPR, including non-technical skills, so rather a wide range. And we also encourage everybody to take this question. And as far as I can see, we have a different result here. So it seems that Germany is in the lead here. And we have Austria as runner-up in the second question. Still some votes going on. Okay, then for the sake of time, I think for the second question, we have the German team here now in first place. Then I would suggest that we conclude this session, and I would hand over to Robin.
Thank you very much, Lucas. So just want to, all remains as we say thank you very much to all of our contributors, to Patrick, Ian, my co-chair Lucas, tuning in the background, and of course all of the teams involved in the production of the videos. Some really good high quality stuff. and stimulus for some very, very interesting discussion, both on simulation and on clinical practice. So thank you all very much indeed, ladies and gentlemen. I hope to interact with you at the latter sessions. We've got a neonatal session that follows shortly after this, and then we have an adult session tomorrow morning. Thank you once again. All the best. Take care.